opportunity to thank you all for choosing Dr. Ekele and I to lead the class. We're giving our best to make sure everything becomes successful. Okay, so today we will start with the West Africa College of Physicians questions, number 1, April 2024. And then Dr. Ekele is going to take us on question number 1A. Dr. Ekele, you have 10 minutes to present. Thereafter, questions, suggestions will come after. Thank you so much. You can have the floor, Dr. Ekele, Robert.
Okay. Good morning, our consultants, our facilitators, and colleagues. Okay, so I'll be taking practice question 1A, and this is the question. It says an 18-year-old SS2 student presents with woody edema of the lower limbs with scrotal involvement. I'm sorry, without scrotal involvement. His mother says he sometimes has discharge with healing. After scaling of the skin, there's associated hyperpigmentation and lichenification. A picture of his lower limb is shown below. So question 1, what is the diagnosis? 2, how will you make a quick diagnosis? What time will you take the sample to improve possibility of making the diagnosis? Then what's the common positive organism in West Africa? What additional diagnostic tests can be done? What's the role of doxycycline in the management of this condition? Okay, so that's the picture. Okay, so the answers, what's the diagnosis? I think is lymphatic filariasis. How will you make a quick diagnosis? I think you could do a thick and thin smear and view the microfilaria, or you could do a circulating filarial antigen test, which is a rapid test with a rapid kit. What time will you take the sample to improve possibility of making a diagnosis? I think the samples should be taken between 10 p.m. to 2 a.m. because that's when you have the highest activity of the microfilaria in the peripheral blood. So what's the most common causative organism? It's the Wuchereria bancrofti, not just in West Africa, Africa generally, sub-Saharan Africa. Okay, so what additional tests can be done? Okay, so if you did a peripheral blood smear, thick and thin, you can also do check for the circulating filarial antigens with the rapid kit. You could do PCR, although that was also done mainly for research. Then you could do serological tests for the filarial antibodies using ELISA. Or you could also view the adult worm using an ultrasound of the lower limbs or the part of the body that is affected. Or you could do a lymphoscintigraphy, which will outline the vessel and also show the adult worm in the lymphatic vessels. So what's the role of doxycycline in the management of this condition? The doxycycline mainly targets the endosymbiotic bacteria or Bacchia, which lives in the adult worm. And then apart from that, it's also macrophyllaricidal. So you can actually kill the worms too. Okay, so I'll just say a little more about lymphatic filariasis. Because of time, I won't say everything. I'll just pick some of the slides and just talk about them. And then when we get the slides, we'll look at the rest of the stuff. So filariasis generally can be classified as lymphatic filariasis, which is caused by Wuchereria bancrofti in 90% of the cases, Brugia malai and Brugia timori. Then you also have the subcutaneous filariasis caused mainly by onchocercal volvulus, onchocerciasis. You also have loesis caused by loa, and then Manzanella streptococcus. And then you have those affect mainly the serous cavities, that's Manzanella pestans and Manzanella ozadi. Okay, so the risk factors to developing the disease includes exposure to mosquitoes, especially people who have multiple bites, living in the tropics, those who travel to the tropical areas, and then fishing and hunting, any condition that will make individuals be exposed to the vectors, that's mosquitoes, which could be Anopheles, Culex, Aedes, or Mansoni. So when you look at the life cycle, you see that there's a stage in the mosquito and there's the stage in humans. In mosquito, the life spend about 2 weeks. The organism spends about 2 weeks on the mosquito. So you have when the mosquito takes a blood meal, it's ingests the first stage microfilariae, which is produced by reproduction, after mating of the adult and female worms. So it takes up the first stage microfilariae, and then there in the mosquito, it's where the thoracic muscles develops the second stage, and then the third stage larva is what is deposited when the mosquito takes a blood meal, and affects in another individual, and then it develops to the nymph and then to the adult worm, which migrates to the lymphatic vessels. So the time from infection to maturation to the adult worm levels usually takes about 12 months, and it's called the prepatent stage. Okay, so we'll look at this when we get the slides. So for the pathophysiology, factors involved in the pathogenesis includes the duration and level of exposure to infective mosquito bites. So the more bites an individual has, the more likely the person will develop the disease. Then the quantity of accumulating worms, adult worms, also determines the level of affectation of the patient, and also the degree of host immune response. So those with very competent immune system that mounts more immune response will have more symptoms. And then the number of secondary bacterial and fungal infections also affects the presentation, also determines the presentation. So the clinical course can be divided into asymptomatic microfilariae when the patient doesn't have any lymphedema or fever, any obvious symptoms, and then they have the acute phases of adenolymphadenitis and other symptoms, and then there's a chronic irreversible lymphedema. The patient could present with fever, adenopathy, testicular and inguinal pain or swelling. Then the skin, you could have exfoliation, hyperkeratosis, acanthosis, and then there's loss of elastic fibers and fibrosis. You have lymphedema of the legs, the arms, the scrotum, vulva, even breasts, and then in some cases, patients could present with chyluria, hematuria, or proteinuria. So the acute syndromes include acute adenolymphadenitis, acute dermatolymphangioadenitis, filarial fever, and then tropical pulmonary eosinophilia, where the patient presents with dry cough, wheezing, dyspnea, anorexia, malaise, and weight loss. Okay, let me not talk so much about the investigations again. I've already talked about that. We also do full blood counts, check for serum immunoglobulin E. We could do histology, then chest radiography in case of patients that present with tropical pulmonary eosinophilia. Ultrasonography, MRI and CT are not very, very helpful, except to rule out suspicion of malignancy. Okay, so the differential diagnosis, there are quite a lot of them. Or any condition that will present with swelling of both lower limbs will be considered as a differential diagnosis, and then swelling of scrotum, like you could have congenital hydrocele, lymphosarcoma, deep vein thrombosis, neurofibromatosis, lipedema, acute bronchopulmonary aspergillosis because of the tropical pulmonary eosinophilia, other causes of hydrocele, even the angioedema, any condition that could cause even testicular swelling. So how do you manage the patient? Your goal of treatment is to kill the adult worm, eliminate and manage the symptoms, and then reduce the transmission as much as you can. So to eliminate the worms, administer antiemetics, prevent and manage secondary infections, manage complications. And then where needed, you can also involve other specialists like urologists, the general surgeon, the plastic surgeon, physician, dermatologist, psychiatrist, dietitian, and physiotherapist. These are some medications you could use, especially the DEC, that's the first line, ivermectin, albendazole, doxycycline. Ceramine is used, but rarely. Okay, so for treatments, if it's a mono-infection with just the lymphatic filariasis, which are Bancrofts, you can use the first line treatment as diethylcarbamazine. You can do 6 milligrams per kg as a single dose. Instead, it's just as effective as a daily dose for 12 days, and then it's really nice to add doxycycline also, 200 milligrams per day for up to 4 to 6 weeks. Then if there's a co-infection, so it's good for you to check when you're investigating, as you do your smear, check for microfilariae of onchocerciasis also. So if it's present, you should treat with ivermectin a single dose first to clear the onchocercal volvulus, and then a month later you can give your diethylcarbamazine. Or alternatively, you can give doxycycline for 4 to 6 weeks, followed by ivermectin. And then you can also do a skin snip while investigating to check for co-infection with lower. So if it's there, if the microfilarial load is less than 2,500 microfilariae per mil, you can treat with DEC for 21 days. And then
you have 1 minute left. 1 minute left.
Okay, thank you. So let me just move on. So apart from the medications, you can also do physiotherapy. Like this, for this particular patient who has lymphedema, I can use compression bandage support to elevate the limbs at night. Rub antiseptic creams on the skin to prevent infection. Psychotherapy for those who are depressed. This young man may be depressed, and also nutritional support is important for them because they have dietary deficiencies. Sometimes they should take low fat, high protein diet. Then you could do surgery for hydrocele, although this patient doesn't have any hydrocele, so he will not need that. Complications include the acute syndromes, depression, impaired mobility and functionality. The prognosis is usually very good, hardly leads to death, and then if it's recognized on time and treated, it's very good. So the prevention, it's good to have community education, have good housing environment so that to avoid the presence of the vectors, use vector control like insecticides, insecticide-treated nets, and then for secondary prevention, it's prompt identification and treatment of cases, and then use of the MDA, Mass Drug Administration, as recommended by WHO. So for tertiary prevention, appropriate management of the complications is very necessary. So let's remember that as take-home messages, remember that lymphatic filariasis is one of the neglected tropical diseases, and it's best to take the sample at night, although filariasis, it's best to take in the morning, 10 a.m. to 2 p.m. So I just added this slide so later we can look at it so that I can see the organisms that cause the filaria generally and then the vector. And then let's remember that there's a plan by WHO to eradicate focusing on all the neglected tropical diseases, including lymphatic filariasis, and then hope to achieve that by two basic components: the mass drug administration and then provision of the essential package of care, which includes treatment of the acute episodes of adenolymphadenitis, providing guidance on measures to manage the lymphedema, then having surgery for other complications like the hydrocele. Okay, so thank you so much for listening. These are my references, and I want to acknowledge Dr. Ogundare and Dr. Ede. I took some stuff from their slides. Thank you so much.
Okay, thank you so much, Dr. Ekele, for that brilliant presentation. It was a job well done. Okay, so the floor is actually open. So please, let's appreciate her in the chat room. Let's appreciate her efforts. Okay, so the floor is open to questions and then contributions. Thank you so much. So we'll start in an ascending order. Okay. Any questions, please? Questions? Okay, everyone is applauding you for a brilliant presentation. Okay, so while we are waiting questions, just an add-on. Okay, the lymphatic filariasis actually causes restrictive lung disease. Actually, how this actually happens is that there's an allergic reaction to the warm lava, and then this is said to occur in the capillaries of the lungs. So that's what brings about what we call the tropical pulmonary eosinophilia. So this makes them to have that nocturnal cough. So over time, there's now damage to the lungs, and that brings about what we call the restrictive lung disease. Then, Dr. Kelly, while we're waiting for questions, for lower, what time is best to take the sample? Like
okay, so for
this. Yeah, you can
okay,
go on.
so
Thank you.
it's best to take it. So the microfilaria has highest activity around midday. So it's best to take it between 10 a.m. and 2 p.m. And just to add to also for schistosomiasis, when you're doing trying to check for the parasite in the urine, that's also the best time to take a sample around
Okay, that's
midday.
good. Thank you. Yeah, thank you so much. Thank you. That's a brilliant one. Around 10 a.m. to 2 p.m. Thank you. All right, so going into the chat room, there's a question for you or a suggestion. The skin snip is for Onchocerca volvulus. They said the skin snip is for Onchocerca volvulus. Then, okay.
Thank you.
Then, but I also saw that under lymphatic filariasis. I think it's also used there. Okay. Then, you can also see lower in skin snip. Okay. Then another person is saying there's room for combination therapy between diethylcarbamazine and ivermectin. Then some other person is saying, please, is this patient at risk of DVT? Okay. This patient at risk of deep vein thrombosis?
I don't think so, because the patient is still mobile. It's just that he has bilateral leg swelling that's caused by that's the lymphedema. That's the abnormal dilatation of the lymphatic vessel and the accumulation of fluid and the worm in the lymphatic vessel. So I don't think it's really, that's just my thoughts. I don't think it's really at risk for DVT, because it's not like they didn't say he's not moving. He's actually mobile.
Okay, thank you so much. Another person is saying black witches fly at night, Brugger and Wuchereria. Okay, so basically what he's trying to say is that you can actually get the samples of Brugger and Wuchereria at night. So that's in the morning he's using black witches fly at night. It's best to get the samples at night. Then some other person is saying just a comment. Wolbachia leaves a symbiotic relationship with filarial worms. Wolbachia produces essential metabolites for the filial worm. When Wolbachia is eradicated by doxycycline, the filial worm dies. Thank you so much, Dr. Amakari Ibinabu. Another person is saying, please talk about Mazotti reaction. Why is diethylcarbamazine toxic? Okay, Dr. Killing. Thank you.
Okay, so the Mazotti reaction is actually kind of like, should I call it, I won't say hypersensitivity, like an abnormal excessive reaction to dead onchocerca volvulus. So that's why most times say don't use DEC for onchocerca volvulus, because that reaction is characterized by fever, urticaria, swollen and tender lymph nodes, tachycardia. The patient could even have hypotension, arthralgia, edema, and even abdominal pain. Usually occurs within 7 days of the treatment. So that's why it's, the use of DEC for the treatment of onchocerca volvulus is discouraged because of this reaction that happens. And I think a study has also reported its treatment of schistosomiasis and spondyloidiasis also. So that's why, if you notice in the treatment, if you have, when you're making a diagnosis of lymphatic filariasis, you also have to check if there's a co-infection with onchocerca volvulus and also lysis, because to affect, to change your management. So if patient also has onchocerciasis, you should treat it first with ivermectin before you administer the diethylcarbamazine. Is one of the ways to prevent this Mazotti reaction. Or you avoid DEC entirely and use doxycycline and ivermectin. Okay, thank you.
Okay, thank you, Dr. Kelly, for that beautiful attempt. Okay, so another question, but you have to rule out venous insufficiency. You know, somebody asked if this patient is at risk of DVT. So some other person is adding on to say you have to rule out venous insufficiency. Then another person is saying in your skin manifestations, I would suggest you use the term lichenification than acanthosis.
Okay.
Thank you so much. Thank you so much, Dr. Jamila. Okay, thank you. Okay, okay. The last comment that just came in before we hand over to our chiefs. Okay, that's what I just read. So in the absence of further questions from the residents, okay, we'll move over to our chiefs for contributions or suggestions. Thank you so much. Thank you. I don't know if Chief Remigus, Chief Bansi, Chief Fatima, Chief Christabel, we have contributions or questions as regards this presentation. Thank you so much, Chief.
Oh, thank you so much, Dr. Briggs, and thank you, Dr. Ekele. As expected, it didn't go below our expectation. You always deliver. Thank you. You did well already, and I must also appreciate the questions, the comments. I think with all of this, it has all been tackled. And I think the dermatologist that was correcting you about like infection and acanthosis, just for people that are listening, in case you don't remember, because if you're not a dermatologist, some terms slip through your fingers. Acanthosis is most like it's an histology thing, something you see on histology looking at the slide. While like unification, skin is thickened. So once you see that skin is thickened, you can see the skin line. Once you start seeing obvious skin line, is like unification. So I don't know how you remember that, but if you cannot remember it, just say obvious skin lines. I believe they will forgive you because you're not a dermatologist. So acanthosis is an histology thing. So once you use it, you just know you don't know what you're talking about. So because it's not something you see physically, it's something you see microscopically, not macroscopically. So I hope that is understood. But it was a wonderful presentation and wonderful comment from the presenter. So thank you once again.
Well, thank you so much, Ma.
You're welcome.
Thank you so much. Thank you so much, Chief Christopher.
Hello.
Hello, sir. You can proceed, sir. Thank you.
Okay. I just wanted to comment that I'm happy with this start. So beautiful, and then the presenter, in fact, as if she's already part of us. She knows how we do these things. She just went straight, answered questions, and then gave us some additional stuff on the subject matter. So that's how we love to do it. And she was on point. She was on time, and see the contributions. So the contributions have been perfect. I really have nothing more to add. I just want to commend you, and I hope we'll continue with this space. Thank you. Let's just go on.
Thank you so much, sir.
Okay. Thank you so much, Chief Bansi. Well appreciated. Okay, so Dr. Ekele, you can please unshare your slide. Okay, so the next presenter is Dr. Momodu. He'll be taking us on practice question 1B. Dr. Momodu, thank you so much. You have 10 minutes to present. Thereafter, questions and contributions to come after. You can have the floor. Thank you so much, Dr. Momodu.
Thank you so much, Dr. Briggs. Good morning, consultants, teachers, and colleagues. I'll be taking practice question 1B. And the question goes to us. It's a 6-year-old man who recently got divorced, took 15 grams of acetaminophen 2 hours ago because he felt his life had no more meaning. He had to rethink that there could be light at the end of the tunnel, so he presented to the hospital. The questions were thus: what are the stages of acetaminophen toxicity and their manifestations? Then list 3 complications of acetaminophen toxicity and what investigations you use to diagnose them, and how would you treat this particular patient? So the answers, I actually put this in a tabular form so that we'll be able to note it. For emphasis, the stages of acetaminophen are called stages 1, 2, 3, and 4. Although there have been other names associated with some of them, but it's quite important that we note into 1, the hours of injection, which puts around 0.5 to 24 hours. That's the first stage, or some people call it the preclinical stage, where this patient typically might just be asymptomatic or might have nausea, vomiting, diaphoresis. They could have pallor, lethargy, and malaise. So when we do laboratory tests or studies at this time, we find out that it's typically normal. Then for the stage 2, between 24 to 72 hours, some will call it the hepatic or hepatotoxic phase, although some other school of authorities will also say both the hepatotoxicity and nephrotoxicity stage around this point. So you see that in this stage, some of the stage 1 symptoms would have resolved, and we have hepatotoxicity and nephrotoxicity present. The patient will complain of right upper quadrant pain. There might be liver enlargement and tenderness when we examine. So if we take a measure of the transaminases, we find out that it's on the increase. This mostly noted around 36 hours after injection for those with the hepatic injury. Then also the clotting profile, we'll see elevated prothrombin time and INR at this time. Other symptom complaint, or what we notice concerning nephrotoxicity can have oliguria and also abnormalities of other renal function. Then the third stage is between 72 hours to 96 hours, where typically people will also say the hepatic failure stage with encephalopathy and even possibly death from acetaminophen toxicity. So here, the liver functions are actually in very high risk and severe values, greater than 10,000 international units per liter. All the different symptoms of all the previous stages are very well present here with multi-organ dysfunction. And if not taken care of, the patient could die here. So, and the fourth stage, which is also called the recovery stage or the recovery phase, here you see that the patient has recovered from this. The patient doesn't die from the third stage. The patient has really recovered. It actually spans about 2 weeks for some of all these symptoms to actually get down. And if we do an histology, the histology is said to, in terms of correction, is said to lag behind. So around 3 months, you can see reversal of some of the periportal inflammation that would have occurred during the injection. So that takes care of the phases and the manifestations. So what complications could occur? Okay, just as we said from the second stage, the hepatotoxicity can occur, and we can see the transaminases quite higher. Normally, it's supposed to be less than, normally it's supposed to be around 40. The liver function toxicity starts increasing around the second stage, and it can go as much as being severe up to 10,000. So the LFT can help us know about the hepatotoxicity. Also, the synthetic nature of the liver, you see that it's the ring we have prolonged prothrombin time and INR. Then, if possible, to do a liver biopsy, you can see hepatic centrilobular necrosis as effect of that. Then also, they could have lactic acidosis, and this basically we can check using the ABG, either venous or arterial, that could help us due to the derangements caused by the acetaminophen poisoning. So because of the liver injury, they could have hypoglycemia, and we can do that we can know that using the serum glucose level. Then encephalopathy too, it's also a possible stage complication, most especially in the third stage. And we want to use the we want to use the arterial serum ammonia. This can help us grade the severity of the hepatic encephalopathy. We can also do brain imaging. The brain CT can even tell us if there are edema or any other findings alongside. The patient could have an acute kidney injury or even worsening up to hepatorenal syndrome, and we can use the kidney function test where we see elevated blood urea nitrogen and creatinine. They could also have even an acute kidney injury from ATN, which will show in analysis you have proteinuria and hematuria. It could also affect the pancreas. We want to do a serum lipase to actually assay some of these complications. So how would you treat this patient? Well, first of all, you have to take a quick, short and precise history and quickly examine this patient. Look at the nutritional status. The patient has recently fasted. If these patients are on medications that will interfere with the cytochrome P450 system, if this patient is on alcohol, it's been said that those with recent fasting, poor nutritional status of alcohol, or those enzymes inducers will definitely propose more toxicity to the body for those with acetaminophen poisoning. Then we have to do a quick risk assessment too. A risk assessment being that you have to quantify the dose that this patient took. You have to look at the formulation of which this patient has ingested. Is it immediate or is it a modified release? You have to look at, is this I'm so sorry. I'm so sorry. So I had a call, sorry. So if this patient took it acutely, just at once, or over time, staggered, or there's a repeated subtherapeutic injection, this is where the patient can take in greater than 100 milligram per kg, or this person is taking a therapeutic dose that is given for him for cure, but now developing liver injury. Then we want to look at the time of injection, because it will help us in our nomogram in terms of how we're going to manage a patient. Then we look out for symptoms too, just as we said, even though we did an examination, these symptoms of the early phase 1 symptoms to be able to assess our risk. Then we definitely have to go, this patient presented within 4 hours. So outside taking the routine investigations like doing the blood sugar, doing the electrolyte urine creatinine urinalysis, we decontaminate do gastric or gastrointestinal decontamination. Here at this point, we are not taking the serum concentration of acetaminophen, just the other ancillary investigations that we take. Then we have to decontaminate. It's recommended that for those who have taken greater than 150 milligram per kg or up to 7.5 grams of acetaminophen who present to you within 4 hours, you have to give them the activated charcoal. And as an adult, you give 50 milligrams a start orally, or you can use 1 gram per kg in terms of weight. So this is actually using the single dose or activated. You can also use multi-dose activated charcoal, where you can give 50 grams within 4 hours for those who have taken greater than 30 grams, or greater than 500 milligrams per kg. An alternative here could also be the use of gastric lavage to do gastrointestinal decontamination. Then just to be more practical, in cases where we can't find this activated charcoal, we can char bread. If bread is char and weight, you can also do the function of the activated charcoal. For this particular patient, we have to wait for 4 hours before taking the serum concentration. And when we, after the combination, we have to observe this patient and check for any signs repeatedly and wait till 4 hours where we'll do the serum acetaminophen level. And if it meets the treatment line of greater than 150 in 4 hours, then we have to start our N-acetylcysteine. Other than that, we're not giving any antidote to the patient. So this patient has had much of a very shocking episode happening. We definitely will need a multidisciplinary approach to this particular patient, be it in the fact that we know that with the gastroenterologist has to be involved, right? Even the emergency physician who has seen this patient in the first place. We're also looking at the psychologist who will see him as a result of this attempt of suicide attempt to actually look into the care. So key points to note, I just wanted to put some definition of terms. For an acute injection, it's actually which comes in within 4 hours. You want to do the gastrointestinal decontamination, and is defined as a patient or a known or suspected acute injection of 150 milligram per kg or 7.5 grams or more of acetaminophen within 24 hours of admission. These are the people, if they come
You got
in
1 minute left.
Okay.
1 minute left.
So then the paracetamol overdose are those that will take greater than 4 grams at one single point that will now present with all these signs of liver injury. So I've initially talked about the repeated super dose. So the pathophysiology just typically dwells on acetaminophen is actually cleared by some of the liver phase trials where it's sulfated and there's addition of glucuronidation, and 90% is actually done by this particular system. And the remaining 10%, 5% actually goes to the cytochrome P450, whereby it's with glutathione is converted to the N-acetylparabenzoquinonimine, which is very toxic. But when they add the glutathione, it becomes non-toxic and it's excreted from them. The remaining 5% are excreted directly straight from the kidneys. So when these systems are overwhelmed, you imagine the cytochrome P450 keeps converting the acetaminophen to the NAPQI, and this is toxic to the system. That is why it's important that there's glutathione, and N-acetylcysteine is a precursor for glutathione and can also bind this toxic NAPQI to become non-toxic for it to be excreted. So it's quite important for those who are even on cytochrome P450 inhibitor drugs. They're also of benefit. That's why when we have very severe acetaminophen levels, there's even need for mepizole, especially greater than 10,000, to be able to counteract this effect and stop the cytochrome P450 from even converting the acetaminophen to the toxic NAPQI. This normally the nomogram has the Romac-Matthew nomogram, which puts at 200, but it's been modified now to put treatment at 150 because of some of the assays or pre-analytical or analytical errors in getting the serum acetaminophen level. So it's put at 150 now. There are also other lines that could help with treatment where you have to look at the issue of double dosing or quadruple dosing, depending on how this patient presents with time and the concentration. I think we'll look at that when we put it. Then the general management of acetaminophen toxicity that comes in very serious presentations are also outlined here. Sorry for time, I might not be able to go through that. But the principles of management, as I've initially said in managing the patient, you do a risk assessment, supportive care, specific treatment where you do the gastric decontamination, gastrointestinal decontamination, antidote therapy, then you manage the complications. Then there are some conditions you must use to stop the treatment of N-acetylcysteine. As we said, for those who are symptomatically well and are fine, you've watched over 24 hours with no problem, and you check some of the lab values, the serum acetaminophen concentration less than 10, INR is normalized less than 2, the transaminases have come back to normal, or they've reduced from decreased from 25 to 50% from the peak, and the patient is clinically well with none of those symptoms. You want to stop the acetaminophen. But if all of these are not met, we still continue it, and we can go at least at 6.25 milligram per kg per hour, or we'll do 70 milligram per kg every 4 hours orally. We'll repeat every 12 hours till we get the stop criteria. So there's also the King's College just added here in case it gets to liver transplantation. And this is for acetaminophen induced to see how you need the criteria met for liver transplantation. These are my references. Thank you so much for listening.
Okay, thank you so much, Dr. Momodu, for that lucid presentation. Well, you're well appreciated. All right, so please let's upload him in the chat room, and the floor is open to questions and contributions. Thank you so much. Okay, while we're waiting for questions, okay, Dr. Momodu, do we use the Romac-Matthew nomogram in a patient who has had repeated acetaminophen toxicity? Like, when do we use it? Hello, Dr. Momodu. Dr. Momodu. Dr. Momodu, can I be heard, please?
Yes, we can hear you. I think Dr. Momodu is the one that maybe is having network challenges.
Okay. So basically, okay, let me just say a little before he comes in. Okay, so the Romac-Matthew nomogram actually is used to assess, as I said, to assess patients 4 hours after the injection of acetaminophen. But in cases where we have the chronic, the patient is already in the chronic phase or in the long-term phase of liver toxicity, we don't use that particular nomogram. So basically, what happens is that their symptoms are non-specific. They don't present in these various stages. So what we normally do is that we just consult, we send such patients to the poison control center, or we send them to the medical toxicologist to discuss the strategy of treatment for this patient, because after that first episode of paracetamol toxicity, they don't present in that same format of the stage 1, 2, and 3, and 4. Their symptoms are non-specific. So in cases of a repeated acetaminophen toxicity, we just refer them to a medical toxicologist to actually assess them and treat accordingly. So that's just what I have to say. Okay, thank you so much. Okay, so going back to the chat room, everyone is applauding Dr. Momodu. Someone is saying, please, I didn't get the alternative to activated charcoal.
Okay, Dr. Mahmoud is saying he was logged out.
Thank you.
Sorry, please, I
Chief
was
Doctor.
locked out.
Okay. All right, thank you, Dr. Momodu, for your wonderful presentation. So I'm in the chat room. So someone is actually asking a question that he didn't get the alternative for activated charcoal.
Okay, for the bread can be charred bread. You burn it, so it can easily char, and you can weigh it in terms of 50 grams and then give, please. That's a ready-made alternative where you can get the activated charcoal.
Okay, all right, thank you. Okay, so Dr. Ekele Roberts is saying for the complications, I think we can look at the clinical manifestations in stage 2 and 3. Okay, thank you so much, Dr. Ekele, for that. Any other contributions? Okay, every other person is applauding you for an excellent presentation. I'm not seeing any other contributions nor questions. So we'll move over to our chiefs for questions and then contributions. Thank you so much, Chief Christabel, if you have questions or contributions as regards this presentation. Thank you so much.
Okay, thank you, Dr. Florence. As expected, Dr. Momodu delivered and he kept to time. I think with your promptings and all, both presenters today so far have kept to time, so and it was quite lucid. I want to encourage those going for the October exam and November exam. I'm sure most of you have done this and solved these questions already. Please want to encourage more participation, more contributions, not just comment. Anything you have read in your own research that you notice the presenter didn't mention, please, we encourage you to share such information so that anyone that is listening to this recording later, first will have the full details of anything concerning paracetamol poison. Overall, thank you, Dr. Momodu. It was a lucid presentation. Thank you.
Okay, Chief Bansi, I don't know, Chief Remibus, Chief Fatima, Chief Kopi. I don't know if we have questions or contributions as regards the presentation.
Mr. Florence, I think you can take a short presentation.
Okay, Chief. Okay, Chief, I think somebody was about to make a comment. Chief Bansi, you were about to make a comment.
No, I agree with Dr.
Okay.
Dr.
Fatima.
Yes. Fatima Bashir. Yeah. Let's take the last one.
Okay, thank you so much.
Okay, so the third presenter is Dr. Sambo. She was logged out.
Yeah, she's been chatting me that she was logged out when she wanted to change stuff. That if they can allow her in to present. Sorry, Chief Okopi, I saw your message. I was logged out too. So when I came in, I'm no longer a co-host, so I couldn't add her.
Okay. She said her laptop, she wanted to enter with her laptop to present, so we did not allow them.
Chief Christopher, I don't know if it's possible to allow her in to present. Hello, Ma.
Hello?
Okay, I was asking if it's possible to let her in.
No, she's in already, except
Okay.
that she's having network issues.
Okay, Dr. Sambo, please can you share your screen?
Thank you.
Thank you so much. Okay, so Dr. Sambo will be taking us on practice question 2A. Dr. Sambo, you have 10 minutes to present, and then thereafter questions and comments will follow. Thank you so much.
Okay. Can you see my screen, please? Are you able to see my screen?
Yes, we
Yes,
can
I'm
just
seeing.
put it on slideshow.
Oh. Okay, so good morning, consultants and colleagues. I'll be taking practice question 2A. So the question is 26-year-old lady has episodes of headache, dizziness, and palpitation for 6 months. An abdominal CT of the abdomen was done, and the images are presented below. So this was the image in the practice question. Okay. CT of the axial and coronal view of the abdomen. So the questions are as outlined here. The first question is, what is the most likely diagnosis? Alternative question could be, describe what is in the image. Is this condition usually benign or malignant? Will this patient require surgery? Which precautions / contraindication need to be considered before surgery? What would you advise a surgeon to minimize complications and list drugs that can be used in treating the condition? So the first question. Sorry, please, there's background noise. Okay. What is the most likely diagnosis? So the most likely diagnosis for this is pheochromocytoma, and the description is as a CT axial and coronal view of a large, well-circumscribed heterogeneous mass in the right suprarenal region with a density of 188 Hounsfield's unit. Is this condition usually benign or malignant? So I think it's a general question about pheochromocytoma. So the answer would be, it is usually benign. Will this patient require surgery? Surgical resection of the tumor is the treatment of choice. Which precautions, which precautions / indications need to be considered before surgery? So the preoperative precautions are alpha blockade with preferably with phenoxybenzamine, which is the prototype non-selective and non-competitive alpha receptor antagonist being used for this specific indication. Adequate alpha blockade generally requires 10 to 14 days with a typical final dose of 20 to 30 milligrams of phenoxybenzamine 3 times daily. High sodium diet and fluid intake is also required to reverse catecholamine-induced blood volume contraction preoperatively and to prevent severe hypotension after tumor removal. Also, the blood pressure should be consistently below 160/90 with moderate orthostasis, and atropine should not be used preoperatively. So for the next question, it says, what would you advise a surgeon to minimize complications during the surgery? So we should try as much as possible. The surgeon should use a single incision and handle the organ with care, and also, if possible, adopt a laparoscopic approach. Then anesthesia should be induced with a non-arrhythmogenic drug like thiopentone, and also should be continued with eflurane. Then if muscle relaxants are needed, drugs that do not release histamine are preferred. So the last question is, list 6 drugs that can be used in treating this condition. So we have phenoxybenzamine, propranolol, nadolol, prazosin, doxazosin, sodium nitroprusside, metyrosine, and iobenguanine I-131. So this is actually a radiopharmaceutical agent that is used for malignant pheochromocytoma. So just a brief overview of pheochromocytoma. They are catecholamine-producing tumors that are derived from sympathetic or parasympathetic nervous system. These tumors may arise sporadically or be inherited as features of MEN2 or several other pheochromocytoma-associated syndromes. The tumors arise from the chromaffin cells of the adrenal medulla. Chromaffin cells are modified postganglionic sympathetic cells that release catecholamines after stimulation by preganglionic sympathetic system. The peak incidence is between age 20 to 40, and about 10% are familial and may be associated with MEN2, neurofibromatosis, and von Hippel-Lindau syndrome. The clinical presentation is so variable that pheochromocytoma has been termed the great masquerader. Among the presenting symptoms, episodes of palpitations, headaches, and profuse sweating are typical and constitute a classic triad. So the triad of palpitation, episodic palpitation, headache, and sweating. The presence of all three of these symptoms in association with hypotension makes pheochromocytosis a likely diagnosis. So this slide shows the 5 Ps and the rule of 10. So the 5 Ps are relating to the clinical features of pheochromocytoma. So we have blood pressure, pain, that's headache, perspiration, palpitations, and pallor. Then for the rule of 10, the 10% are extra-adrenal, 10% are bilateral, 10% are malignant, 10% occur in children, even though some guidelines now quote 20%, and 10% are familial. So this is this table is showing the biochemical and imaging methods used for pheochromocytoma, and their sensitivity. So the 24-hour urinary test, we have the VMA, which is highly specific, and then the metanephrine is highly sensitive. Okay, the plasma test, we have the catecholamine, which is sensitive and also but not as specific. Then we have the free metanephrine, which is more sensitive and also more specific. We have other tests like the chromogranin A, which has the same sensitivity and specificity profile as the catecholamines. Then the CT scan, which is the diagnostic modality of choice, is also sensitive, has a high sensitivity and specificity. So we have other imaging modalities like MRI, MIBG scintigraphy, somatostatin receptor scintigraphy, and dopamine PET study. So there's preliminary data regarding this imaging modality. So the differential diagnosis include essential hypertension, anxiety attacks, use of cocaine or amphetamines, mastocytosis, carcinoid syndrome, intracranial lesions, which can present with features of raised ICP, clonidine withdrawal, autonomic epilepsy, and factitious causes, which can be from sympathomimetic amines. Then when an asymptomatic adrenal mass is what is identified, the differential diagnosis would include a non-functioning adrenal adenoma, aldosteronoma, and a cortisol-producing adenoma. So these are my references. I don't know if someone has questions or contributions. Thank you very much. Sorry, I got lost.
Thank you. Okay.
Yeah.
Thank you so much, Dr. Sambo, for keeping to time. That was an excellent presentation. We appreciate your efforts. Okay, so the floor is open to questions and contributions. Please let's applaud her for this wonderful presentation. Okay, so while we are waiting for questions and contributions, so just an add-on. Okay, you mentioned the rule of 10 in pheochromocytoma. Okay, so for the malignant transformation or the malignant tumor or the malignant type of pheochromocytoma, most times they are dopamine secreting. Then also for the investigation for the metanephrine, we actually do plasma and then urine. So we have the plasma, we do the plasma metanephrine, and we also do the urinary metanephrine. So the urinary metanephrine is specific, meaning that it is 98% specific, while the plasma metanephrine is sensitive. So I think in choosing, I think we can actually do urinary metanephrine is 98% specific, while plasma metanephrine is sensitive. Just an add-on to what you said. Then the kind of surgery we do for them is laparoscopic retroperitoneal adrenalectomy. So that's what we do to minimize complications and all of those things. Then expected side effects that can occur following the removal of the adrenal gland could be adrenal insufficiency and then hypotension. So that effect, that hypertensive effect is actually lost. So they can present with hypotension and then with adrenal insufficiency. That's what they may present with following removal of the adrenal gland. Thank you so much. Okay, so going into the chat room, everyone is applauding you. So we are here to get.
Sorry, Dr. Florence. Dr. Hay is raising his hand.
Okay, thank you so much. And you can speak up, please. Okay, Dr. Yeah, please speak up. Thank you. You have the floor.
Okay. Yeah, thank you, Chief. Thank you, the presenter is a very good one. Mine just to add one or two things as what you said. One of the question asks whether it's malignant or is it benign, and it's rightly, as you said, is benign because it's only 10% that is malignant, and has been highlighted by the. Then 90% are usually benign. Only 10% is malignant, and those preoperative things that you need to do before. I think first you have to mention that apart from all those things that you mentioned, somebody is hemodynamically stable. Patient should be hemodynamically stable. Then you need an expert surgeon and anesthetics. They're also very, very important because of the possible complications and the nature of the surgery. And for the rule of 10, they actually extended to 10, not just 5. Apart from what you mentioned, it could be, again, 10% could have chance of recurring, and 10% are calcified, and 10% are not usually associated with hypertension, and 10% are incidental. So in case, apart from those extra adrenal, malignant, familial, multiple, so you may need to know about this to this addition. So thank you very much. It's a very good one just to mention those. Thank you.
Thank you so much, Dr. For that great input. Okay, so Dr. Sambo, everyone is applauding your beautiful presentation. So in the absence of questions and contributions from the residents, move over to our chiefs. I don't know if Chief Success Obangba, Chief Fatima, Chief Christabel, Chief Pansy, or any other chief that has a contribution or questions as regards Dr. Sambo's presentation. Thank you so much.
Dr. Kelly Robertan is up. Dr. Kelly, please go ahead.
Okay, please go ahead. Sorry, Dr. Kelly, I didn't see it. Thank you.
Thank you so much, Dr. Sambo, for the beautiful presentation. Okay, I just wanted to add to what Dr. Yahya Mohammed said about the preoperatively before surgery, patient should be hemodynamically stable. Means that the blood pressure should also be controlled. So I don't know whether you can talk about the blood pressure control. You know, there's something about alpha blockade before use of beta blockers. I don't know if you can throw more light on that.
Okay, so I mentioned that you should start with an alpha blockade to before the beta blockade. This would ensure that there's no how would I put it? There's no unopposed alpha activity. So you should start with the alpha blockade and then you do the beta blockade. Because if you start with the beta blockade, you may still have episodes of hypertension. The goal is to prevent hypertension. So you do the alpha blockade and then the beta blockade. But I don't know if there's someone who can better explain this in the house.
The endocrinologist in the house, I don't know if they have any comments. I know we have endocrinologists in the house.
Okay, Chief Ugo, Chief Adeze is here. Dr. Adeze Ugo is also here. She's an endocrinologist. Ma, I don't know if you have anything to say about this. Dr. Adeze Ugo. All right.
Okay, good morning, Chief Bansi, Chief Shitu, and the rest. Okay, this is Dr. Mamza. So I think this is one of our questions in part 2 endocrinology subspecialty, that's 2022. So exactly the way it came out as general medicine exam, that was the station in part 2 for subspecialty. So this question concerning the alpha blockade, I think it's very important. It's one of the most important treatment in a patient with pheochromocytoma. So once you recognize a patient that has pheochromocytoma, the first thing is to start the alpha blockade, and that should be started immediately. So why you need to do that is to unoppose, just like she mentioned, Dr. Sambo just rightly mentioned. But the treatment is when you start with phenobenzamine, you start like 10 milligram, which about 2 times in a day. Then you gradually increase up to like 20 milligram 4 times in a day. You can use other options like dosazocin if you don't have phenobenzamine. Then apart from that, things that will tell you that you have achieved adequate alpha blockade, because you have to achieve adequate alpha blockade before you start your beta blockade. So how you know that is when you check the blood pressure, you expect a postural drop in the BP and also the pulse and the hematocrit. So how you measure it, you check the sitting pulse pressure. The pulse pressure should be around 60 to 70, while your BP should be around 130, 80. Then after that, then you can start your beta blockade. And your beta blockade, you can use the propranolol, usually higher dose of about 20 to 80 milligram 8 hourly. Usually we give these patients by mouth, except if they are contraindication. If not, we only give them through the mouth, and it should be done within the hospital. Then during the surgeries, it's important that the endocrinologist, the anesthetics, and also the surgeon that is specialized, urologist preferably, that is specialized in treatment of patients with pheochromocytoma, because this is an emergency in which even before the surgery, the patient should be in ICU. And immediately after the surgery, the patient should be moved to the ICU, because the patient needs to be monitored in the ICU because complications can occur, especially during the intraoperative mishandling of the gland and other things. The BP can shoot. So intraoperatively, ideally, they should be antihypertensive, intravenous, like the nitroprusside should be available within, or phentolamine, or even IV nicardipine, because anything can happen and the patient can develop arrhythmias. So I think these are the things I want to say concerning that question. Thank you.
Thank you so much, Ma.
Thank you so much, Ma.
I don't
Okay,
know if
so
once he's around, if he can add other things.
Okay, thank you so much, Ma. Okay, so we'll hand over to the chiefs.
Hello, Dr. Mamza. I think you've just said it all, and it won't be more than this. It won't be more than this for part 2 exams. Are we together? The class coordinator.
Yes, we are listening to you, sir. We can hear you.
Yeah. Okay. I said Dr. Mamza has made it very clear, and I think for the general medicine, it's okay. I don't think they will go beyond this, unless you're an A candidate, and then they want something more. And then the next most important thing is actually the sensitivity and the specificity. I don't know if somebody has mentioned it. The plasma metanephrine is more sensitive, while the urinary metanephrine is more specific. Are we together?
Yes, we are.
Yes, sir.
Yeah, okay. Yeah, plasma metanephrine is more sensitive, sorry, while the urinary metanephrine is more specific. And these days, they're selecting either one of them can actually give you results, because for example, in plasma metanephrine, it's about 90 something % sensitive. I'm not sure, but I know it's 90 something. Okay. Well, the specificity is about 80 something. Meanwhile,
No, 90
for the
something
urinary,
still. The
okay,
difference
90
is not
something.
much. 90 something, yes, sir.
Exactly. So the
Difference is
difference
not much.
actually
And
is
that's why
not much.
you prefer to go for it. Because
Exactly.
urinary you do like twice, and there are factors that can affect. So I don't really want to go to that details.
No, not for this class. Not for this class. Yeah.
Yes, not for this class, those details.
All right. Thank you very much, Dr. Mamza.
Those drugs that need to be checked and other things that can affect the plasma and the urinary acid. So I don't think it's important for this class.
Yeah. All right. Thank you very much, Dr. Mamza.
Dr. Hamza, give us the stuff, Jerry. Give us, Biko. Give us the stuff.
Chief, because I've already started trying. Okay, sir. So what we do is usually the plasma, just like you said, you know that sensitivity is ability of a test, as a screening test to check the true those that really have the disease. So if you want to do a test, you go for the sensitivity, this sensitive one than the specific one. Of course, the specific one truly tells you, but at least if the sensitivity tells you that the person it's low, then that means the ability of the person to have that disease is not there. So that's why we go for the plasma metanephrine than the urinary metanephrine. Except if you do the plasma, it is borderline and you are still suspecting, that's when you go ahead to do the urinary metanephrine. Because for the urinary metanephrine, in endocrinology, once we want to do urine test, you need to have like 2 or 3 times. You need to take sample, and it's a 24 hours urine. So, there are factors that can affect even the time collection and all those things. Because except if it is being done in the hospital, patient might mix it, because just like we collect 24-hour urinary protein, the first void you discard, then you start taking it, anything if you want to go to bathroom. So there are so many things that can affect that. So collecting is usually a problem. Then there are other drugs that can also interfere with these things, especially you look at the patient, what the patient is taking, because they mention things like banana, pineapple, fruits, and other things can also affect the urine. So that's why we leave that. But for the plasma, of course, there are some drugs, but you can be able to withdraw the drug before you start taking the samples. Then there are some antihypertensive that are valid that might not really affect it. So if your patient is on things like levodopa, tricycline, phenothiazide, and calcium channel, they can really not affect the plasma metanephrine ACE inhibitor, especially if you need to control the blood pressure. You can really allow the person to be on such medications. But if you want to tolerate this, and patient is on things like alpha blocker, hydralazine, domperidone, and the rest, you need to stop these medications before taking. These are things that can affect the urinary catecholamines, but for the plasma, they don't really affect it. Then other things are the clonidine and the rest, which can also decrease. So these drugs can either increase or interfere. But things like ACE inhibitor, calcium channel blocker, your patient can be on it. It does not really affect the urinary catecholamines. So those are the things that you need to look out for. So they usually affect the urinary compared to the plasma. So thank you.
Thank you, Chief Mazza. Thank you so much. We're 9 minutes beyond our usual closing time. We try to keep to time.
Hello.
Hello.
Yeah, just to add to what Dr. Mamza just said.
Okay.
Yeah, physical stress can also interfere with the results, apart from the drugs Dr. Mamza mentioned. Dr. Mamza mentioned about 2-3 tricyclic antidepressants, levodopa, beta blockers, right? And then chlorpromazine. You understand? So I think those are the few I can actually remember. You understand? So maybe candidate can now check up the others. So those are the drugs apart from major physical stress. Yeah. Thank you very much.
Oh, thank you, sir. Thank you, Chief Bansi and Chief Manza and all our chiefs. Thank you for your comments.
And I think, sorry, in addition, there are some things that probably they might ask, who should be screened for a pheochromocytoma? So if maybe you're attending towards A, they can ask you. So patients that have bilateral adrenal, those that have the age of greater than 50 and the rest. So, and those that have family history should be screened.
Hello, Ma, are you done now? Hello? Okay, I think she's done. So thank you, everyone. We have to close this class, please.